I am very honored today to introduce our speaker of a very important topic which we are going to present in this webinar. She is Sister Devisha Karadia. She did her BSc with honors and is a member of Royal College of Optometrists. She graduated from Plymouth University in 2014. She has 10 years experience in primary care settings within Bristol and Somerset regions. She is passionate about her profession and her specialist interest in management of myopia and dry eyes. She is very lucky to be blessed with Swami's presence in her life since childhood. She is an active volunteer who has been involved with the Cheltenham Sai Group and has taken part in service activities in the region. She has also participated in medical camp in Prashanti Nilayam. I am sure you will learn a lot about this pediatric myopia, which is a very concerning topic for the day, as it is causing a lot of concern in parents and the clinician as well. Today's question and answer session is conducted by Dr. Shankavi, Sai Rangan. She has completed her medical training in July 2021 and currently doing pediatric specialty training in London. She has a keen interest in teaching and community health. Dr. Shankavi is currently the service coordinator in Mill Hill Science Center. She is also involved in many service projects, and she's a gifted singer as well. She's very lucky and has participated in medical camp in Puttaparthi and Prashanti Nilayam in July 2024. I'm extremely grateful to our beloved Sai Baba, who has given this opportunity, and thankful to Sathya Sai Service Organization of UK, who has given us this platform to continue our ongoing webinar activities and brought to you many important and burning subjects during the COVID time, and we hope to continue the same in future as well. May God bless you all. Thank you.
My humble pranams at the lotus feet of our dear Swami. Jai Sai Ram, respected elders, brothers and sisters. Thank you, Dr. Upadhyaya. Your work is truly inspirational to so many healthcare professionals. It is with great joy that I share with you today my knowledge of pediatric myopia and the effects that our evolving world is having on our vision. I will start with some of the common terms used by optometrists. We will talk about the development of a child's eyes and move on to the future of our vision and our visual needs. The prenatal development of the eyes begins at just 4 weeks, and the eyes are fully formed at 26 weeks. Newborn babies are hypermetropic, which is long-sighted, and they can see blurred images and predominantly in black and white. As the eyes continue to develop, they will develop their colour vision and depth perception, which is the ability to judge distances. So they can start grabbing for things successfully and eventually will be able to catch a ball. Typically, children will be seen for annual eye tests from the age of around 4, where glasses can be prescribed if required. If you have any concerns earlier, then you must consult your health visitor or local optometrist, who can signpost you to the most appropriate clinician. Eye tests are important in both children and in adults because we can not only prescribe a pair of glasses to help you see better, but we can detect any early signs of any problems that can be treated or referred on to your GP or the hospital eye department. I urge everyone to have their child's eyes tested from a school age to ensure timely detection and treatment of any eye conditions. Here you can see the age-normal prescriptions for children. The powers shown are completely normal. Long-sightedness is expected all the way up to the age of 11, and often without a need for correction. Seeing these numbers on your child's prescription copy is not unusual, and it does not mean they require a pair of glasses, nor does it mean they will never need a pair of glasses. There is a lot of confusion around long and short-sightedness, so I hope I can clear that up for you. Long-sightedness is where the vision is clear in the long distance, but more blurred at near. This is known as hypermetropia, and it will be represented as a positive or plus sign on the prescription. Hypermetropia is normal in children, as they are still growing. If a child is symptomatic of long-sightedness, then glasses can be prescribed, normally for prescriptions stronger than a plus 0.75. Symptoms may include, but they are not limited to, headaches, squinting, double vision, or closing one eye. Your child may not be able to tell you about some of these symptoms. It is important to observe how they interact and engage in tasks. Are they suddenly disinterested in reading? Do they bump into things more often? Do they close one eye to watch TV? Some of the symptoms, and sometimes some of our findings, will require further investigation. So it is normal for the optometrist to take longer to check with some extra tests, and we may need to use eye drops to get a more accurate prescription. Short-sightedness, known as myopia, is the opposite of long-sightedness. It is when you are able to read up close, but you struggle to see far away. Typically, you will need glasses to see the whiteboard at school, watch TV, or drive. As the diagram shows, the eyes become too long, so require a lens to push the light rays backwards in order to focus the image. It is important to detect short-sightedness, as the prescription will help your child's educational endeavours and prevent headaches. Short-sightedness is becoming more common globally, and the chances of reversing short-sightedness without surgical intervention, like laser eye surgery, are very slim. The final prescription type I'm going to talk about is astigmatism, which can sound quite scary and often associated with words like stigma, but this is completely normal and very common. It's where the surface of the eye, or the lens within the eye, is more rugby ball shaped rather than like a football. And it means that the light is focused at two different points, which can be in front of, behind, or either side of the retina. Astigmatism can be corrected just as easily as both long and short-sightedness can. Now, symptoms to watch out for include headaches, squinting, frowning, struggling with glare from bright lights. Blurred vision isn't always reported, but you may pick up spelling mistakes, or you may struggle to differentiate between the letter O and a C or a G, or an E and a B. And this is really easy to correct with a pair of glasses. I'm going to come back to myopia now, and the importance of myopia. There is a lot of information here, so we can pull it apart point by point. Firstly, as I briefly mentioned, there is a global increase in the prevalence of myopia, or short-sightedness. It's predicted that by 2050, 50% of the global population will be short-sighted. myopic. This is not dependent on a country's wealth or education, but our social norms as mankind. Research strongly supports the increase in myopia to be linked to our more sedentary lifestyles, where we spend increased time indoors, at computer screens or devices. Though an ethnicity and genetics plays a role in the likelihood and the risk of myopia, the environmental factors can still accelerate and exacerbate myopia at a younger age. The long-term effects of myopia are not only blurred vision and the need to wear glasses or contact lenses full-time, but there are more clinical and health-related concerns which are associated. With a stronger myopic prescription, the eye is larger and longer than a normal eye. This increases the risk of eye conditions like glaucoma, cataract, myopic maculopathy, and retinal detachment. Whilst some of these conditions can be detected early and treated effectively, they can also be sight and life altering. When the onset of myopia is detected at a younger age, the chance is greater that you'll be more short-sighted as you grow older. This is compared to if you were to become short-sighted at a slightly older age. So with all this information, I want to be able to help you understand how simple lifestyle changes can delay and reduce the onset of myopia, especially in children, and the treatments that are available to slow it down. So I'm going to talk to you about the factors that affect the onset of myopia and some of how we can change or delay that onset of myopia. So firstly, quite unavoidable unfortunately, is the family history of short-sightedness. And there is a greater risk of becoming short-sighted if a child has two parents who are short-sighted themselves. But I do find a lot of parents telling me that their child has become more short-sighted than they were at the same age. And this is most likely due to environmental factors. So the time a child spends outdoors can strongly influence the onset of myopia. And there is a lower risk when a child spends longer outdoors. The general recommendation is to spend at least 11 hours a week outdoors. Now, living in a cold country, this can be quite tricky. However, it is important to find an activity that promotes your child looking at far objects. So whether that be a sport, time in the garden or out walking, promoting that distance viewing is really important. The other factor, which is important in how we can delay the onset of myopia, is what I would call the working distance of near tasks. Now, the working distance is the distance between the eye and the object the child is viewing, whether that be a phone, a computer, an iPad, a book, sort of homework tasks. Now, that distance should be greater than 30 centimetres, ideally at an arm's length. So I recommend to all of my paediatric patients that they hold their arm at an L shape rather than a V shape, because that immediately puts a distance between what they're viewing and the eye. I will try and show you that at the end and demonstrate it so you can see it a little bit better. Now, policing the time and the distance of where phones and books are being held is quite tricky. And so there are some smartphones that will have an inbuilt setting for the detection of the phone being held too close, and it will prompt the user to move the phone away. So I would strongly recommend this is activated for anyone under the age of 16 to not only increase that distance between the eye and the device, but to create that awareness of where things are being held. And naturally that will increase as we spend that time prompting. Now, I mentioned screen breaks there as well, and that's again something that I often get asked as an optometrist, and sometimes I feel like I'm being the bad cop in the testing room. But I always recommend that children spend 20 minutes at a time doing a prolonged close work activity, and then take a break to look out of a window, wander around the garden, before going back to a close work activity to relax the eyes and reset them back into that distance viewing point. So now we know a little bit more about myopia and its importance. I'm going to tell you about myopia management. This is a relatively new term whereby we look at how we can slow down the progression of myopia. It's now widely available, and it is successful in slowing the progression of myopia following onset. Slowing myopia is important, as it can help reduce the long-term risks and complications that are associated with high myopia, as we mentioned before. So the image at the top of the screen shows hyperopic defocus. This is where the spectacle or contact lens corrects the prescription throughout. Now, our eyeballs are not flat. Therefore, the image is projected behind the retina, which is the back surface of the eye. This unfocused image behind the retina then stimulates what we call hyperopic defocus, and we find that the eyes grow towards that unfocused image. Then the central focus becomes more blurred. So the eyes have become longer and we've become more short-sighted. The image at the bottom of the screen shows myopic defocus. This is where a specialist lens, either a spectacle lens or a contact lens, corrects multiple focusing points to mimic the curvature of the eye, and it projects the image in front of the retina. This unfocused image stimulates myopic defocus, and this is what we have found slows the rate of change. So we maintain clear vision centrally, and we prevent the growth of the eye, therefore slowing down the myopia. Now, the table here shows how we can predict myopia, or how much myopia we predict will change over the course of a year without intervention. So this is greater amongst the Asian population, and you will notice that the younger the child, the greater the rate of change we can expect. So if your child were to become short-sighted at the age of 8, they may be more short-sighted in 10 years' time compared to the first prescription or the onset of myopia being at the age of 11. Now, with myopia management lenses, we can slow these figures down, we can slow the progression down by around 50%. In the UK, there is a number of ways we can now provide myopia management, and it is a good idea to speak to your local optometrist, who can provide options or refer you on to a colleague who is maybe more experienced in myopia management. In the first instance, I would always recommend wearing the prescription full time. Even though vision may seem manageable without a pair of glasses, sometimes this can accelerate the prescription further. Now, soft contact lenses with something called dual focus technology have been available for a number of years, and this has been successful in slowing down the myopic progression. The dual focus technology gives the myopic defocus, which we've just spoken about, to slow the progression. Now, contact lenses are perfectly safe for children to wear. With the correct wearing schedule and good hygiene, there is little risk of infection, and actually children are much better than adults at looking after their contact lenses and remembering to put them in and take them out. The wearing schedule must be followed, as it is a treatment rather than optional, in order to see the success that we have done with the soft contact lenses and the dual focus technology. Now, there are also a number of lens manufacturers who offer a myopia management spectacle lens, and this is something that's relatively new in the UK. It works with something called lenslets within a lens, which give a different focusing power to mimic the light in front of the retina, thus giving us myopic defocus. And the glasses should be worn according to the treatment plan and is most successful when worn full time. Now, the other contact lens type of correction for myopia management is something called ortho-K or orthokeratology. It's a hard contact lens that is worn overnight, and therefore when you wake up in the morning and take them out, you can see. This is very specialist, and a set of bespoke hard contact lenses are made to measure and fitted to each patient. The lens will alter the shape of the front surface of the eye to correct the prescription. Now, these lenses were found to slow the rate of myopic progression and are probably the most successful in slowing myopia. Originally, they were a cosmetic treatment, but have had great success. They do require a large investment in time and financially, and this treatment is not available at every optician's. It requires a longer fitting process and some additional courses for the optometrist. There is one pharmacological therapy, and it's called atropine therapy. It can be prescribed privately, and there are eye drops. They are eye drops that dilate the pupil and relax the muscle that controls the lens focusing, something called accommodation. It's not yet licensed in the UK, and the results have been previously varied. Given this information, it's important to discuss the use of atropine as a treatment with an ophthalmologist, and you should always try the other interventions as well. Now you have lots of information to digest. I'm sure you're eager to book yourselves and your children in for sight tests. Now, the majority of high street opticians will hold contracts with the NHS to cover the cost of an eye test for anyone under the age of 16. If spectacles are required, a voucher can then be issued towards the cost of them, and a free pair of glasses will be covered with a voucher. But any additional costs will apply for treatments and anything more specialist within the lens. And these prices will vary according to the opticians and the practice that you go to. Now, additional assessments may be recommended, and that is entirely your choice, to determine if myopia management should be explored. These are chargeable, but they won't be compulsory. So, as we come to the final part of the presentation for today's session, I just wanted to leave you with some links to the lenses that are available in the UK for myopia management. And if any of today's session or the myopia management options seem interesting or relevant to yourself and your child, then you can definitely contact your local optometrist to see if they provide any of these lenses. And if they don't, or if there's anything extra that you require, they will signpost you to the most appropriate optometrist or ophthalmologist who can help you on your journey with myopia management.
Sarah, I'm Sister Devisha. Thank you so much for a very informative presentation on paediatric myopia. That was very, very useful information there and lots of take-home messages. So thank you so much. I'm just having a look at the chat to see if there's any questions. There aren't any at the moment, but if you do have any, please do pop them on the YouTube chat and we can go through them. I've just got a few questions myself, if that's okay. You mentioned that there's lots of lifestyle modifications, such as reducing screen time, increasing the outdoor activity, and better lighting. How effective do you think how effective are the lifestyle modifications alone in managing or preventing myopia compared to the optical and the pharmacological treatments?
So I think the lifestyle modifications, which I mentioned about the working distance, let me just show you very quickly, because I know that I promised everyone that I would show them how I would hold a book or a phone. So rather than holding your arm in a V shape like this, you should hold it at an L shape a little bit further away. So the arm makes that L shape rather than a V. This is just a bit too close, especially for children. And I know lots of children will read in bed and have their books really close, but actually it should be a little bit further away, just to try and get the eyes focusing that a little bit further away. So the lifestyle modifications really are most effective pre-myopia, so before a pair of glasses for myopia are prescribed. And this advice is given by the optometrist pre-myopia, and that's why eye tests are so important, to sort of go as a preventative, like you go to the dentist, so that the modification can be made before we become short-sighted. And then once a child is myopic, that intervention is most effective if it's optical or pharmacological. Lifestyle modifications at that stage won't necessarily have a huge difference or make a huge difference.
Okay, thank you. And I mean, I work with children myself, so I know sometimes implementing some of these management strategies can be difficult and challenging in children, especially the younger age group. What do you think are the biggest barriers to adopting the myopia management strategies that you've spoken about for parents and for teachers? And how do you think these can be addressed in clinical practice?
So again, I think splitting it into pre-myopia and then once we become myopic, pre-myopia, I think that's really tricky. It is really tricky to find a way of getting your child or your class to hold things further away and not so close to their faces. And you know, that is really tricky, and it is that constant reminder that might break that habit. In terms of screen time, you know, limiting it to 20 minutes at a time, or screencasting, as I mentioned, trying to put things a little bit further away, a monitor rather than an iPad is better. The biggest barrier to adopting any myopic intervention and trying to get a child to wear a pair of glasses. So especially if you've got a low prescription, you can still see most things without your glasses, but actually the full-time use of those glasses is what's going to slow that short-sightedness down. So that's that is quite a barrier. And in terms of myopia management and how we implement that and how we kind of stress the importance, I think that's also really tricky because there's a huge cost attached to myopia management, and that's not NHS funded yet. Hopefully we can keep lobbying and we'll get some NHS funding at some point, but it is roughly on average about at least £50 a month per patient. So if you're a parent of multiple myopic children, that becomes expensive. So cost is a big barrier as well, and that's something that that's why the lifestyle modification earlier on will help in the future.
Yeah, thank you. I mean, cost, you said cost is a big barrier, and I can imagine for a lot of people that's something that they would definitely think about, especially if genetics plays a part and there's quite a few children in the family who are myopic. Speaking about costs, do you think the corrective do you think that the contact lenses, the cost of it is justified? How feasible are contact lenses in children, and is the cost justified to use it in children?
So I think if you weigh up the cost of myopia management spectacles and myopia management contact lenses, they're very much on par. There's not a huge, I don't think you'd find a huge difference between the cost of either. In terms of children wearing contact lenses, they're the easiest patient. Once you've taught a child something, they will listen and they will be very regimented on how they put the lenses in, take them out, whether they're less likely to overwear them, they're less likely to swim in them because they don't make their own rules, they listen to rules. And the risks of complication is a lot lower in the studies that have been done, especially in soft contact lenses for myopia management. There's a very much a low risk attached to these contact lenses.
We've actually got a question that's come up on the chat. Thank you for that. The question is, at what age does myopia usually stop progressing?
That's quite a tricky one. This is always a question that comes up, and I think it is quite tricky to predict for how long myopia will progress, and it often depends on the onset and the lifestyle. So if you became myopic at the age of, so I take myself for example, I was myopic about the age of 14, and my prescription didn't stabilize until I was 28. But I spent a lot of time studying and looking up close. And so I think lifestyle and computer work and iPhones and things like that have a huge impact. So I think it's really tricky to say at what point the prescription will stabilize.
Yeah, sure. No, thank you for that. And you did mention in your presentation about the progression of myopia in different age groups. Do you mind just expanding on that? So how does the progression on myopia differ between children who are prescribed glasses quite early on versus those who begin wearing glasses later on in childhood?
So there is a greater rate of change seen in children who are prescribed glasses or become myopic at younger age. That's generally what we tend to find. And I would imagine, don't quote me on this, but I would imagine it's because children younger are growing a lot quicker. So when we hit our teens, we tend to grow a little bit less in height, whereas a 6 or 7 year old is growing at a much more rapid rate, and so the eyes will change at a more rapid rate as well.
Okay, thank you. That's a lot of useful information there. We're just checking if there's any more questions. Please do pop them in the chat if you have any. I just wondered, we've spoken about lifestyle modifications. We've spoken about prescribed glasses and using pharmacological treatments as well. Does nutrition play a role in the development or progression of paediatric myopia at all?
So I don't feel that this is as widely researched as maybe it could be. There's some loose sort of connection with vitamin D and vitamin D deficiency and the cause of myopia. So, that's one thing, but I don't feel like it's reported enough for me to give a recommendation on nutrition. But I know that spending time outdoors increases dopamine levels, and that's something again that could be linked.
Yeah, sure. I mean, I guess it's one of those things where you just need more research to see if there's a link between that. What do you think are the long-term effects of myopia management strategies? So using things like contact lenses, you mentioned atropine as one of the pharmacological treatments. What are the long-term effects of these kind of treatments, and are there any risks that are associated with a prolonged use of it?
So myopia management as a long-term treatment, optically, so contact lenses and glasses, there isn't any point at which they would be a disadvantage. One thing that we do find is that if a child is sort of 17 and learning to drive, wearing myopia management contact lenses, they might get a bit more glare. They might struggle a little bit for those sorts of things into adulthood. So at that point, you might take them out of myopia management and monitor them more regularly to make sure that we don't get a rebound effect. But that's something that each individual optometrist will review, and it's very much patient dependent, because some patients can get starbursts in their vision and carry on driving and it not cause any problems. So every patient is different, every child is different. So I think it's really about catering care to each patient that you see and giving them that love and that care that they deserve, essentially. In terms of the atropine therapy, there's a study called the LORIC study, which suggests that 5 years of atropine therapy is enough, and that they will, when they originally did the studies, the ATOM 1 and ATOM 2 study, that they found a rebound effect after using higher concentrations of atropine. So the lowest of concentrations were actually the most successful. They were used as a placebo and were really successful. So they carried on with the atropine at a very low percentage, which is all that would be prescribed if it were prescribed by an ophthalmologist. And that is most successful in Asian patients, actually. There are more sort of contraindications with a Caucasian population in atropine therapy, and probably why it's not so widely used in the Eastern world at the moment.
I see. Thank you. We've actually got a question from someone in the chat, from Mrs. Patel. Would you recommend any dietary supplements for young individuals to help sustain good eye health?
So general eye health, it's a varied diet, lots of vegetables, colourful vegetables, and omega-3s as well, which is something that's not always easy to get into our diet, but flaxseed is really good. So yeah, as a vegetarian or a vegan, that's flaxseed is a really good source of omega-3s, which are meant to be really good for your eyes. But again, I wouldn't say there was enough research to say you need to eat more carrots. That's a myth.
Yeah, thank you. Thank you, Ms. Patel, for the question. You mentioned about.
Again, I think it's very much an area of interest, an area of growth, but there isn't anything specifically because of interfering with homework or lifestyle or those sorts of things. There's no hard and fast rule, but I always recommend 20 minutes of close work at a time, and then letting the eyes look into the distance to refocus out, to sort of reset and refocus out again, keeping that working distance a little bit further away. And some of the studies that have been reported in East Asia have actually shown a greater progression of myopia in children who spend more than 45 minutes working at a distance of less than 20 centimetres. So that 20-minute rule is quite a good one based on the research that we've got.
Thank you. I mean, I think that's something that as adults we should also probably adopt as well. That's a really good tip, and I guess we forget about it because using screens is so it's very much part of the new norm now, and it's what society does. So it's just remembering those things and implementing it in children at a young age. You mentioned about ortho-K lenses, the corrective night use lenses. How useful do you think these are in controlling myopia? I know it comes with a big cost. So are there any other corrective or controlling measures similar to that can be used as well?
So ortho-K is probably the most successful in managing myopia, and it was, like I mentioned before, it was mostly used as a cosmetic treatment, but actually the researchers were finding that the short-sightedness following orthokeratology treatment for a number of years wasn't progressing the myopia as it would with spectacles or soft contact lenses, and that's why it is so successful. It requires a lot of hard work in terms of looking after the lenses, cleaning them, making sure they're ready to be worn again, and they do come with risk of infection because of the nature of how they're worn and used. They are quite hard to come by. Not all optometrists will be brave enough to prescribe them and will refer on, which I think is absolutely fine. It's a huge investment in time from everyone involved, but it's really successful.
And do you think that would, is there any chance that would be subsidised by the NHS? I know at the moment it's not, I understand, but do you think that's a potential for the future?
I think not just orthokeratology, but all myopia management intervention is something that should be considered for NHS funding. However, what will happen in the future is really difficult, and every patient is different, like I mentioned before. And you will get, we do get patients come in and we'll recommend glasses and not contact lenses, or contact lenses and not glasses, because every situation is different.
Yeah.
Based on hobbies and things.
We've got a couple of questions here in the chat. One is by Amit. How many hours a day can the child wear contact lenses? And do you recommend special glasses along with contacts?
And so again, this depends. So the contact lenses, the soft contact lenses that I fit most regularly are absolutely fine for 12 hours use a day. We normally recommend a day off during the week or the weekend, so that the eyes are not completely covered over all the time by a contact lens, and they get that opportunity to breathe and get the oxygen from the natural atmosphere. So that's, 6 days a week for 12 hours is quite usual for myopia management. And then in terms of the glasses alongside the contact lenses, I think it's a real area of interest at the moment, because there hasn't been enough research to show dual treatment as a successful intervention. So a child who was going to wear their myopia management contact lenses for 3 days a week, but glasses for 4 days a week, there's no research to show that that's going to be just as successful as wearing one intervention over the other. So I think if you're wearing contact lenses 6 days a week, and a normal single vision pair of glasses should be absolutely fine. Equally, if you're going to wear the glasses 5 days a week and a few hours at the weekend for contact lenses, then the normal single vision contact lens would be suffice.
Sure, thank you. We've got another question from our RA. Would myopic lenses on spectacles, I think that's supposed to say, would myopic lenses or spectacles or glasses pose challenges in driving?
So the myopia management spectacles, I believe, are licensed sort of up until the age of 16, which would be before we started to learn to drive. And at that stage, we would possibly look at just a single vision pair of glasses for driving at that point. But again, every patient is different. And then the contact lenses, again, once you start to learn to drive, it depends on how the child is adapting, or the teenager is adapting to wearing the contact lenses for driving. If they were going to report things like ghosting, we would then maybe look at doing something slightly different in terms of their correction.
Sure, thank you. We've got another question here. Does myopia in children at a young age pose challenges with anxiety and self-esteem for children? And what can adults do to help children normalise myopia? Yeah,
so myopia there's a huge increase in it, and I think it's really challenging to understand from a child's point of view without having been myopic at a very young age. Mm-hmm. But I think there is that anxiety, especially if it goes undiagnosed or undetected. If you can't see things coming towards you, you become more anxious of what might be coming towards you. And so I understand that can be, pre-diagnosis, that can be quite a tricky feeling for a child. And I think once a child's in a pair of glasses, it's making it just part of everyday life. And if a parent's got a pair of glasses as well, wearing those as opposed to wearing contact lenses, to encourage the child that it's normal and it's okay to wear a pair of glasses. But I can understand that, yes, anxiety can play a huge role, because it's something different, it's something foreign, and it's unknown as well.
Yeah. I mean, I guess also having different things that children would like, so their frames, and allowing them to choose which frames they want, and making it a bit more of a playful, using play-based approach when they come to the opticians to have their eye test. I guess all of those things would help.
Absolutely. And also choosing a pair of glasses, like you said, the child likes, but also not feeling that you have to have your glasses from the practice that you have your eyes tested in. I think that's quite important, and finding a frame that you like, or going back a different day on another day and having a second look, or getting a second opinion, or your parents trying glasses on themselves, and just having a bit of a giggle about it.
Yeah, great, thank you very much. I I can't see any more questions in the chat. If you've got any, please do pop them in. We've got a few more minutes left. Thank you so much, Devisha. That's been really, really useful. I've learnt a lot myself. I hope everyone else on this webinar has too. Yes, we've just got another message just saying thank you. Very useful webinar. So yeah, it's been great to learn a bit about myopia. Very, very informative. Talking about, you know, the differences between the different kinds of myopia, and you know what we can try and implement in children, both as clinicians but also as parents and teachers, to try and help slow down that progression and the different types of management for myopia. Thank you very much.
Thank you, Divya, for your excellent and very informative presentation. And I'm glad actually both our presenter today have got a pediatric interest in child care. And Shankavi, thank you very much for such a lively question and answer sessions. And you can see how many questions have come from the audience. I'm sure this is a very burning topic. I'm sure that you are aware that this year World Sight Day was dedicated to myopia. And as you say, the 50% of the population by 2050 will be short-sighted. It is a very alarming thing because people do not understand the problem associated with short-sightedness and complications and other things like that. So you very beautifully highlighted that. And I am sure now that after this talk, parents will be more aware and more careful with children for advising and guarding how much time they are expending. Today's news was that the government is putting a bill that children will not take the smartphone or iPhones to the schools. That's a very good thing because during the recess and in between they chat with each other. That probably will prevent. So there is a lot of things are coming up. But these talks, which, this talk which you have presented really will generate a lot of interest. And I'm sure that we will have another pediatric sessions on that. I'll also like to thank our media team, especially the medical media team who works very hard despite of their full-time work to record and present these sessions for your benefit. Sister Gayatri needs a special thanks because she gets such a wonderful presenters like you have seen today. And in the end, I would like to thank our beloved Swami who has given this opportunity to bring such wonderful presentation. And you can see our youth is really coming out with lots of information. They work very hard to bring all this information to you. And thank you, listener, for giving your time. May God bless you all. Saira.